It's obviously no accident that we have such a big turnout. This is a very hot topic today, as it has been for a while, and especially since the beginning of last year when President Obama's American Recovery and Reinvestment Act really gave us a very big push forward in the U.S. investment in health information technology, and not just the investment, but the commitment to developing a system, a national system of HIT. And there aren't any better speakers to help us better understand all of this than Jean and Paul, and we're very pleased to have you here. So thank you and welcome.
Thank you.
Well, good afternoon, everyone, and thank you for having us. I guess I've got the lavalier. I've got the first portion of the presentation, but while we're introducing ourselves and all, I think it's good for Paul to introduce himself as well. But I'm Jean Balgrosky, and I wear several hats here at UCLA. I am lecturing in health information technology, teaching, helping establish some new educational programs that include specialization in HIT for the MPH programs and the executive programs and all, as well as a new course that's going to be offered in fall, HS 440A, for anyone who's interested. And can you hear okay? Very good? Okay. But I'm also a doctoral student, and I'm hoping to finish my PhD this year. So I wear a couple different hats, and my goal after 20 plus years as a chief information officer at Scripps Health in San Diego and Holy Cross Health System back east is to take what I've learned over the years and kind of had to figure out on my own and with the help of many colleagues around the country to become a CIO and develop systems and share that with people so that as they are developing their careers in healthcare, they can take advantage of that information. And Paul, would you like to introduce yourself?
My name is Paul Fu. I am an associate professor in the Departments of Pediatrics and Health Services and Public Health. I work down clinically at Harbor UCLA Medical Center, where I run the pediatric hospital medicine program, so I handle all the pediatric inpatients. And then over here, I teach Health Services 401, which is actually this quarter, Wednesday, today at 2 o'clock for anybody who's interested. We welcome auditors. And it's a course on public health informatics. And my area of interest really has to do with the ability to take large consolidated data sets, such as the ones being generated by electronic medical records, and use them to help push policy and different ways to have valid analyses that cut across multiple disciplines. The center does a lot of great stuff, and I'm actually going to show a couple slides from Ask CHIS as we go through some of the challenges, I think, in information delivery in the next few years.
Okay. So at the beginning of the presentation, I'm going to walk through a lot of the definitions and about HIT and what's happening in electronic health records and how we get from here to there, and about the government's programs to stimulate growth and adoption of electronic health records. Of course, creating lots and lots of data for policymakers and others to use for analysis and other things, and Paul's going to really focus in on that informatics and analytics. So, alrighty, so I mentioned that we are developing some programs here at UCLA, and we're very excited about this, and we've gotten a lot of support from faculty members, and many of whom, or a few of whom are in this room, and we're really appreciative of that. So our goal is to develop a world-class, full-fledged degree programs for master's work in the executive level, at the extension, and in the day program in the Health Services Department, ultimately with PhD program and DRPH. So we're moving full steam ahead with that. So just getting some definitions together here. What is happening? What is health information technology? It's basically computerization and making electronic health information, healthcare services, the administration of healthcare, from finance to business intelligence and clinical intelligence, which gets into the analytics and use of information. It's the communication and telecommunications between people, organizations, patients, payers, government, and all parties. And health information exchange is a very important part of the government's push for stimulating health information technology adoption. and we will go through specific definitions on each of these terms. The electronic medical record, just to quickly, kind of clarify so we're all on the same page, is the patient record in an electronic form, and it resides in a system that is specifically designed to support all the various types of users with specific role-based security so that they have accurate, complete data on a timely basis where they need it in the format that they need it. And it includes decision support for clinicians, reminders, alerts, decision support tools, and then links to other bodies of information so that basically it helps these knowledge workers have all the tools at their hand. Electronic health record, which is basically an extension or a broader scope than the electronic medical record, is a longitudinal record. Whereas the medical record is within the four walls of an institution or a clinic or a physician's office or a group practice or what have you, it is organization-centric. Whereas the electronic health record is more person-centric. It covers, yes, what happens in the institution, but it also includes what happens with a person when they're healthy, so that they can keep track of their baby visits and their vaccinations and immunizations and all the things that they want to do to help keep their families and themselves healthy. So the differentiators are geographic, because health takes place many places, organizational and over time. The primary and secondary uses of an electronic health record system. Institute of Medicine, of course, has been very involved in helping push along this agenda and define some of these terms for us and help launch many important initiatives. Sorry, I looked down, I guess I shouldn't do that. Primary uses, of course, patient care delivery and all the patient support processes supporting clinicians as well as the business side of healthcare, and patient self-management so that people can take a more proactive and active role in their healthcare management. I think Kaiser is a very good example of how they have extended from within their four walls out through the web to their patients and really involve people through portals and things like that. And then secondary uses. Now that we're implementing systems and producing all these very specific, discrete clinical data elements, we are no longer dependent in research and policy analysis and other kinds of analytics on using administrative data or claims data, billing data, which has been the predominant source of healthcare data to do analyses with. We're no longer going to be dependent on that, so it's going to be a big shift for everyone. And it's going to be a lot to manage for us, but it's going to be very good, because once we get good definitions and standardized definitions for discrete clinical data elements, we're going to be able to do a lot more specific and accurate, I think, research more quickly with this. So education, regulation, research, public health, surveillance for homeland security to pick up disease processes that might be starting out and spreading, and policy support. And of course, we're going to talk at length about that. One of the highlights, if you will, of the electronic health record is a computerized provider order entry, or CPOE. And I'm sure many of you have heard of this, but these are clinical applications and really one part of the heart of an electronic health record that makes it more tied directly to the intelligence and the control of the clinician, so that we can catch orders before they happen, catch them at the point of order, so we can have a tighter process. So these are clinical applications that allow clinicians, and usually we think it initially started out computerized physician order entry, but then we realized, of course, that other providers can use this as well for their orders and all to process and enter orders. And these systems rely on other systems to function. So and we're going to go through a little model of how these all fit together. But a clinical data repository, which is an organized database of all the data about a patient in the institution or in a broader extended ambulatory and inpatient and care setting. So we need to have good clinical terminology and dictionaries that get used for this all to take place. Good interfaces between the user and the system, of course, and then good messaging systems and standards whereby these things communicate. We are getting information that is coming out gradually in research that there are benefits that we all imagine that there are benefits associated with this, but to actually measure the benefits and how we achieve these is very important. So this is what the research is really striving to do. is to create evidence as to where we actually are seeing benefits. Maybe we're seeing benefits we didn't anticipate. Maybe some of the benefits we anticipated are not as easy to achieve as we thought. These things don't happen automatically. So to get the benefits, it takes very careful work in terms of how these systems are introduced and how the implementations are organized. You can't just load some software and expect magic to happen. It really takes workflow to be redesigned and people to be retrained and job descriptions to be rewritten and roles to actually maybe migrate more back to patient care, away from some of the paper processes that they are traditionally grounded in. So it's a big deal to implement these systems in an institution. We know, and so here are some of the benefits, and I'm not going to go into great detail, but we know that it can have a very positive effect on clinician productivity. We do have some sites where the opposite was true. It's all in how you implement, is again, I think, a key point. And good results in terms of accuracy of medication order entry, which is, of course, a problem that we want to solve as medication errors. So here's a model that helps kind of create a conceptual idea for you about how various systems put together. I think sometimes people talk about an electronic medical record, an electronic health record, as if it's one thing. And it's really many things that are put together into an organized, really portfolio, an architecture in an organization, whether it's a large hospital-based institution or, again, a physician practice or what have you. Most hospitals and large practices, and of course, will have a lot of departmental systems, and I imagine many of you are familiar with this, who have worked in healthcare for some time, or even all of us have experienced this when we're patients, where different departments have their own functions and their own systems, so sometimes you have to be registered every place you go, right? If you walk across to go to the laboratory, all of a sudden they're asking you the same information again. You go, I just told somebody that, and clipboards and all of that kind of thing. I mean, we're making progress, but lots and lots of niche systems. Laboratory, radiology systems, OR management systems. Patient accounting is a very large and complex system in most organizations. All the general financials. So when we speak about electronic health records and how things are changing in healthcare, that's all well and good, but it's important to remember too, there are many other systems that all have to be in lockstep with all of this, and that a chief information officer and other people responsible have all these things to manage and to make sure that they work in perfect unity. So be nice to your CIO. Then many, many monitors and instruments. At Scripps Health, where I was for 8 years, CIO, we, during Y2K, did our inventory, and there were 22,000 different monitors and instruments that we needed to manage, take care of, make sure that the right data were getting fed to the right places and things like that. So this is not an insignificant piece of the portfolio. And then PACS, which is Picture Archive Communication System, which is a system by which you manage images. Images, more and more results are being delivered in the form of an image, and so these systems are becoming a very important part of the electronic health record. But these are all just departmental systems, and so those silos of information exist everywhere in organizations. The idea behind electronic health record, electronic medical record, is to pull it together into an organized, unified whole. So this organized drum, if you will, is really the primary guts of an electronic medical record, or electronic health record, depending on your scope. Master patient identifier, which is a unique patient identifier, so that no matter where a patient is seen in a health system or a doctor's office or clinic or network of all of those things, they have one identification number, so all their information can be 100% positively identified and then combined in this clinical data repository, which becomes the longitudinal house for their information forever. So you can see it just gets filled up over time with their information. And this all then talks back and forth. Certain of these systems have to have interfaces into this organized clinical data repository, which is, again, kind of the centerpiece, if you will, of the electronic health record. And then the clinical decision support, rules and alerts, lots of things that the computer is very good at. Finding abnormal results, putting up a flag, doctor, are you sure you want to order this antibiotic? The patient's allergic to penicillin, or things like that. So good ways, and then everybody's connected with some web-enabled tool. And then all these data, and this is where we get to the analytics and the policy use of this for any reason we want, is all of these data then can then be put into a warehouse or an organized database that's intended for analytics. And these are two different kinds of systems. You cannot do your analytical work and lots of ad hoc queries on an electronic health record or electronic medical record that's being used to take care of patients. It has to have, sub-second response time, and it has to be available for patient care. And they're actually constructed differently. But there are systems then that are constructed for analytics, and they have different tools attached, and that's how we learn, and then we create information for ourselves, and we can then adjust our workflow and start to create kind of that learning cycle there. So all these functions are interrelated. I'm going to wrap up here real quickly and hand it over to Paul. But this slide shows how different processes in healthcare delivery are related. And there are front-end processes that all need to be then integrated and work together, having to do with identification of the patient and their data, registration, admitting, scheduling, all that front-end stuff, getting people into the emergency department, and then the clinical processes with all the orders and results and things like that, and images, and then we've got the back-end processes where we can do automated charge capture and billing and supply chain management, and this is where we gain efficiencies. Again, one of the promises of the electronic health record. And all of this is really part of what we think of when we talk about the electronic health record. Another kind of electronic health record is the personal health record. And so many of you may have, some of you are using one of these. There are organizations, Google is putting one out, some providers, some payers are putting them out. They are intended just for what they sound. It's your way to keep track of your own health and your well-being. So those are in a much more infant stage, I would say, and they're very variable right now. So I think we're very early in our evolution, but ultimately that will all be linked together so that it will be able to flow securely from the person to the organization and payers and back. The last definition is the health information exchange, which is electronic clinical data exchange among providers. So this is part of the government's push. They want to be able to gain efficiencies to reduce redundancy in repeated tests so that we don't have to pay for the same test over and over and over again. That if a person has been seen in a clinic or a hospital in a community and then they end up in the emergency department across town or whatever, that the data about them is available electronically to help those clinicians get a good head start. And there are local and regional organizations that are developing these. Lots of benefits expected. RAND did a big study published in 2005, expecting that if $121 billion were spent over 15 years to implement electronic health records, that $531 billion of benefits would be gained over the same time period in savings. Okay, and I'm going to just fly through this and hand it over to Paul here and start doing a little tag team.
All right. So just so you kind of have the lay of what we're going to do, I'm just going to talk about the field of biomedical informatics really briefly, and then I'm going to throw it back over to Jean so she can do some about health IT policy, and then I'll show you some, hopefully I can get this thing to show live some sites that I think are interesting websites in terms of how health IT, the back-end systems, are being used to influence health policy. So biomedical informatics is pretty basic. It's basically the intersection of information technology and biomedicine, and it can be very, very broad. So as you can see, there's two axes. Your x-axis is you can get everything down to the molecular or cellular level, and we typically call that bioinformatics. So you may hear that, you can hear proteomics, you may hear genomics, that kind of stuff. That's where those are what we call basic informatics research. And then you have stuff on the complete other end of the spectrum, which is like large population data sets. Think CDC, think Healthy People 2010. That's kind of like the public health side. That's the large populations. You'll also hear many terms because, unfortunately, in the field of informatics, there isn't a common taxonomy. So you'll hear people say clinical informatics. For example, I am the director of clinical informatics at Harvard UCLA. I have colleagues who call themselves medical informaticists. I have, there's biomedical, there's health informatics. So there's no real standard term, but the only common word that people use is informatics, and that's just to show that you are taking technology and you're interjecting it into an academic discipline. So just to tease you, I'm reading a book by Jake Adelstein called Tokyo Vice. I don't know if any of you have read that before. It's pretty interesting. He is a reporter. He was embedded into the Tokyo Metropolitan Police Department for a while, and one of his police informants told him this: people are good or bad. Information is not. Information is what it is, and it doesn't matter who gives it to you or where you steal it. The quality, the truth of information is what's important. And when we talk about health, information, technology, we're talking about a process which is really very crude in capturing information that we want to use to make policy decisions. When you think about it, what is health information technology designed to do? It's designed to capture data that reflects an interaction between a patient and a clinician. That's really what it's supposed to do. What we're trying to do is take that data, extrapolate it, and build it so we can actually influence and make decisions on policy. And that means pulling data from other sources as well. So speaking about policy, I'll turn it back over to Jean.
Thank you. All right, the American Recovery and Reinvestment Act, we've all heard of, and many folks are experts about that in this room, has a component called the HITECH Act, or the Health Information Technology for Economic and Clinical Health. So why is the government doing this? Why have they initiated this? We perceive on some of those pages that I went through at a very quick clip, and you can look at the benefits yourself, but there's perceived and real benefits that could be extremely beneficial. So high value is out there for us to somehow harvest, right? Unfortunately, the electronic health record adoption is low. And there are numerous different studies now. There will be more soon. Actually, that's on my dissertational topic. And but for physicians, it's somewhere around 10% in their offices. For hospitals, depending on who's being measured and what portion, 15 to 20%. The CPOE is about, in a recent survey of CIOs throughout the country, only 19% said that they were ready with a 10% threshold of use of a CPOE capability in their institutions. So the bar is not being set very high in this. Just are 10% of your providers using the computer to place and manage their orders, and only 19% of our institutions can say that they are. So that's pretty low. Another problem is these systems are very expensive, and it's not only expensive to initiate them, to buy them, and to implement them, but to support them long term. And it's kind of like being pregnant and you have a child. I mean, it's a forever thing. When you implement electronic health record, that's it. It's going back to paper. It would be about the most painful thing I can imagine. They are difficult to implement and support, and very disruptive. You know, we've heard about Rogers and the disruptive technologies research and things. This is very disruptive in busy clinical environments where there's sick and hurt people that need to be taken care of. The government estimated that there's 55,000 or more HIT professionals needed in order to accomplish these goals. So we're short a whole bunch of folks. So there's jobs that are going to be out there for people, which is very interesting to some of my students, I've noticed. Work. You can read this, and I'm sure many of you are very familiar with this, but 20 billion, now Sajid informed us, and when he lectured for my class, that it's actually 34 billion plus 2 billion, and so it's about 36 billion. This 19.2 you've heard a lot, is actually with the savings netted out. So that's how the government has described it. So it's a lot of money, and there are stimulus dollars that physicians and hospitals will be eligible to receive each year for several years, and if they achieve meaningful use. And meaningful use is certain capabilities using certain functions of the electronic health record. Because again, one health record is not another. And so one of the things that's difficult to measure about what adoption even is in this country is the fact that some organizations have implemented maybe some portions or some e-prescribing or whatever, and they say, oh, I've got an electronic health record. Well, no, you don't. So it's a government's attempt to create a definition around what it really means to have meaningful use and enough of the core of a real electronic health record to say, yes, you've done it. And so and then the penalties start to apply in terms of reimbursement if they don't achieve that. Some of the key technologies for healthcare reform, again, these meaningful use technologies, one of them is health information exchange. Another is the electronic health records, and another is computerized physician order entry or provider order entry. Other key technologies will be the analytics, and this is where the policy benefits can really come into play. Clinical decision support provides clinicians with real-time information that helps them make quick, better decisions because they've got better information about their patients and other more technical things. This slide it includes some of the meaningful use technologies and where we are in terms of the adoption. And this, I'm sure you're accustomed to, which is kind of the adoption curve here, from introduction to innovation to excellence to efficiency. And so we are very early on in the use of the personal health record, the ones in red, health information exchange, a little further along, but still pretty new. Analytics, electronic health record, towards the middle there, computerized clinician order entry, and e-prescribing is a little further along because it's more specific and a little bit easier to kind of encapsulate and implement. So, all right, so it gives you an idea of how far we have to go.
So I mentioned before that most data is captured, a lot of clinical data is captured at that encounter. That's your, as you're looking at the top left-hand corner. What happens then is that your classic way of doing things was a physician writes a note down in handwriting. It gets filed in a chart someplace. And then when somebody needs to do some sort of analysis on it, to do a report, to tell somebody what's going on, how many diabetics they have in their practice, or what is the epidemiology of a disease in a certain area, you aggregate it manually. You pull a bunch of charts, you look for a bunch of information, you print a bunch of reports, aggregate that all, even in an Excel spreadsheet, and then you do your analysis. Somehow that winds up massaged into policy, and theoretically a policy will eventually complete this virtuous information cycle back and influence the point of care decision. What's happened over time is that technology really has changed based upon healthcare has really changed in terms of how it uses technology based upon what's been available. And the first EMR systems, Mass General, 1965, they've been around for a really long time. But in general, 1960s, 1970s, you were really focused on getting administrative efficiencies and productivity. So I'm talking about the vast majority of systems out there, not the niche systems where you had a lot of people doing informatics or basic information science research. Things like Moore's Law just came out. You had structured programming languages that made health information technology applications possible. A lot of these things were transaction-based, patient accounting, stuff to generate bills, clinical transaction systems, keeping track of the labs and what got done, what didn't. Then in the 80s and 90s, you had this kind of emerging revolution of technology that became portable, relatively speaking. You have personal computers that could go on desks instead of having to be, dumb terminals linked to a mainframe. You had local area networks. I used to work for Microsoft, and my specialty was networking. So, banks were like over the moon when all of a sudden everybody in the office could have access to their financial systems. I mean, this was truly revolutionary in being able to push a relatively low-cost device to users who could do something with it. In the mid-90s at UCLA in the main hospital, we used to have like 4 different computers at the nursing station, one to access lab results, one to access the the administrative ADT systems, admission, discharge, transfer. So these were single purpose, they're connected to different networks. But what we've seen over the last 10 years or so is that the emerging network bandwidth is pretty much ubiquitous now. We have the internet, we have wireless networks, and we're changing our focus. Technology now is not so much counting efficiency and productivity. People are saying, okay, we've done so much with technology, what's the next step? What is the next information thing that we're looking at? And as you know, the IOM has these reports coming on that focuses on the quality chasm, or so quality. And as a result, you have a bunch of systems coming out that are focused on helping deliver higher quality patient care, like decision support systems. So this is what I would consider to be the modification for a digital age, for how information comes through. And the numbers represent where I see the 3 big challenges that health IT has. First of all, it's capturing the right kinds of data. Because like I mentioned previously, an electronic healthcare record is really designed to capture the clinical encounter. and it's very workflow dependent. Jean mentioned some of the issues, and the disruptive effect of technology. It is hugely disruptive because what happens is that you're not changing the technology to fit the workflow, you're changing the workflow to fit the technology. So you can do some shopping, but basically that's what happens. But when you think about it, what are the data elements that somebody's going to want to ask? For example, there might be a researcher in this room who has done some research on the incidence of asthma and air pollution. I don't know, is he back there? But what happens is that those are the kind of questions that people will want to be able to get to. So, you enter in your patient information. If you enter in a diagnosis of asthma and you happen to have a school listed there, wouldn't it be great if something popped up and said, patient attends a school 300 feet from the Harbor Freeway? I mean, maybe you could do something about that then. Maybe you can be a little bit more proactive in terms of your patient care. That's the kind of data that's not currently being collected at the point of care. In large part, that's because these are not systems designed to capture data related to a multiple determinants of health model. I'm a determinants of health guy, so I think there's lots of different things that influence health. But that's not what EHR systems do. EHR systems are really focused on doing it. And just because we collect the data, it's often free text. There's no standardized taxonomies, there's no standard vocabulary, so I couldn't compare it between different providers and different systems, and that's going to be a challenge. Number two, it's how do we improve the modeling so we can address the determinants better, so we can create more comprehensive models. And again, this is a gap because we have a pool of data, we have lots of different data sources, and people are being able to do these great high-quality studies that pull multiple different sources of data, like air quality, hospital ER admissions, and discharge data, and create some very comprehensive reports that can affect policy. And the last one is, now that we have so much more data and so much more multifactorial data, how do we make that easy for somebody to understand? I've had the fortune or misfortune of working with a few legislative offices. And I have to say that the expertise level of the person delegated to be the legislative analyst for healthcare is extremely broad. I have met some people literally 3 days after they graduated from college who are now in charge of a House of Representatives, their health portfolio. They're responsible for gathering the information. So, and then I've also talked to people who have been doing healthcare for 15 years and know the studies better than I do. So there's a huge gap, and so you have to be able to make it easy to conceptualize and answer the questions. So when you have questions and answers, this is oversimplifying it, but from an IT or a data perspective, you can break it down to look like this. You have questions and you have answers. You have simple questions and complex questions. You have simple answers and you have complex questions. And complex answers, excuse me. The ones in yellow are the hardest for a computer system to do. Okay. A simple question is a simple answer. That's easy. Like, what's pi? Right? It's an equation, and then you generate an infinite number of questions. Complex questions and complex answers, that's a little bit easier too, because you give them a hard question, then you can just kind of this is what I'm doing to you. I'm just throwing tons of information at you and letting you parse through all that stuff. The hard ones are when somebody gives you a very complex question, and you have to provide them with a simple answer, something that they could use, something they could regurgitate. We have a CNN attention span now. That's what we're having to deal with. The other one is a simple question, but a complex answer. Okay. And one of the things that is, making it difficult is that, like I mentioned, I just ran a Taylor series to show what I'm trying to say. You have a parabolic curve. What we're trying to do is we're trying to match the curve representing healthcare. It's not linear. So what we're trying to do is develop higher levels of approximation so that as we present these analyses based upon this large pool of data, we're doing a better job of representing the true underlying causes. Now, people are doing great research in these areas in multiple different silos, but we're not doing comprehensively yet as a country is really being able to get a handle and influence health technology, use health information technology to influence health policy on a cohesive level. But there are places that are starting to do this and starting to do this really well. I would like to switch over to my laptop just to do this live. Is that okay?
I don't know who set that up, so.
It's not going to screw anything up. I can just throw my laptop on it. That's okay.
Yeah.
Okay, cool. The first kind of tool that I want to show you that answers simple questions is Google. I mean, just by show of hands, how many people will go first to Google or Bing or another search engine when they have a basic question to ask? Yeah, I mean, it's like ubiquitous now. So I have medical students doing this. Fever, pain, dysuria, right? I mean, seriously, you know, I'm like, come on, we pay for resources to use besides Google, don't do that. So, I mean, like I said, it's really good for simple answers. What it's not good for is when you want to figure out, say, what's my health risk? You know, what am I going to do? So this is a heart disease risk. Doesn't, I mean, sure, it lists you a bunch of sites, but it's really buyer beware. You don't know the quality of any of the stuff that you're getting into. Okay, so there's nobody who's validated all that information for you. But you can see there's some sites like CDC, that's great, but I mean, there's lots of them. I mean, how do you parse through all the information? That's why a lot of people try to game their way up to the top of their search engine lists. Anybody familiar with Wolfram Alpha? Okay, the guy who invented Mathematica, he said that I'm going to create a computational knowledge engine that basically you can type in a free text question and it's going to give you an answer, something easy for you to do. So, for example, heart disease risk. Let's see what it tells me. And this is what it tells me. Okay, this is actually using stuff based on Framingham. So it allows you to go ahead and do things. I'm now 55. My LDL is bad. My HDL is worse. Oops, and I'm a smoker. Let's say I'm a smoker. Should I be a diabetic too? And now it's going to compute all that stuff for me. And so it repeats all the information for you. It gives you a risk of developing coronary heart disease based upon the Framingham data. And then it shows you the impact of these different factors upon, oh, you can't really see. Let me see if I can.
Yeah, we can see it.
Can you see it?
We're fine.
Okay. Oh, that's not totally what I know. So you can see this percentage this is how much your risk is affected by what your LDL and stuff like that. And this shows you your cumulative risk as your age increases. So by the time I hit 85, it looks like I'm going to be dead. So this is a really personal way of doing things. They're trying to deliver information, trying to take a complex question and give a simple answer to it. Okay, they're trying to say, some guy goes to a website and goes, what's my heart disease risk? And puts this information in. I mean, what you could do is you could do a lit search, and you can go like up to date. You then, use different calculators and approximate it, different things. Or what most people do, they know they can do this, they'll go here and assume somebody's on the back end work to make sure it works correctly. So that's I think it's a pretty cool tool. It's an interesting way of presenting information. Now, I'm sure everybody here is familiar with AskKISS, or at least they better, or they're not going to admit that they're not familiar with AskKISS. I actually use this as a demonstration when I go international and I talk to other countries to say, this is how you should be presenting your health data for your analysts to use clinical data. Because what happens is that it is an aggregation tool and allows you to break things down by geographic area, by subject matter, and then you can compare them. I mean, it is really a powerful tool that allows somebody to drill down information and get a complex answer for a complex question. Okay, because complex questions, because you can have all these different things. Let's pick. I forgot to log in. See, I actually have a login.
So for those of you who aren't familiar with what Paul is doing,
Blasting through this, sorry.
There's a little plug for us. AskGIS is a query system that we developed to enable users with many different levels of technological capacity to access data from the survey we do called the California Health Interview Survey. And it's a comprehensive survey of California's population with a lot of geographic subsetting of the sample possible. So I don't want to take more of Paul's time, but I just wanted to let you know what he's
One of the things that we've found that is the most powerful way to display information is either in a tabular format or in a geographic format, because people want to know what's relevant to them in their communities. So I've already picked the geographic area that I'm interested in, and I would really like the help menus here. And they're very clear, and get my results. So 2x2 column, a table. I mean, how much more effective can you disseminate information? I mean, this is a really, really powerful tool. Okay. So Cal Hospital Compare is another tool that's put out by the California Healthcare Foundation. Brigham UCLA Medical Center. And this is when you have a very, I won't say simple question, but a very focused question that you want to answer. On the back end, they have done a tremendous amount of work aggregating all this data. UCLA has done a ton of work aggregating this data. The people who have, here is the UCSF, they've taken all this information and they have put it into a format that you can now put a front end on. This is the front end. Gives you the hospital. Let's take a look at the heart attack. Okay, superior, poor bilateral heart cardiac catheterization. That's not so great. But I mean, this is really easy to use. So if I was a person of making a policy decision, then I wanted to look at a specific hospital, or I want to compare to other hospitals in my area. Let's compare to Cedars. Okay. That's a good way of doing it. You can actually compare it to a large number of hospitals too. Again, this is taking complex data sets, multiple data sets, and putting them all together. And this is addresses two of the different questions. The first one was, this is multi-institutional. So in terms of collecting the data, that first challenge, somebody managed to collect all the data from two different institutions, standardize it into a common format, and then have a common analysis to them. I'm not going to show you Hospital Compare, but this is HHS's version of Cal Hospital Compare. It basically does the same thing. That's also very effective. PAHO, the Pan American Health Organization, they're another example of an organization with a ton of data that comes from many, many different sources. And keep in mind that these sources of data vary tremendously in their technologic sophistication. The US basically sends them like data files that are pre-formatted, they just plug in. Other countries in Central and South America have a little bit of a challenge in sending the same level of data. I think everybody has Excel now, but when you think about it, there's a huge difference between in a spreadsheet and being able to manipulate data out of a database. So what PAHO does is they have made a software product called Tableau, available for free as a Tableau viewer. Unfortunately, it only runs on PCs and not Macs or virtual machines. But it allows you to take the data set that they've collected and aggregate it and move it around. What I like about the PAHO site is that it's very graphical. Some of these other sites tend to be a little bit more text-based. You have to do a lot of reading. What PAHO does is they have these pretty little pictures. And computer research next things. You can actually go ahead and pick a higher level of detail if you wanted to. And it'll give you your more granular data as well. And this is just selected indicators across multiple different countries. So you can see all this information. It plots some of them across the way. So it's a pretty capable system. It takes a lot of data and helps to answer some more simple questions like, what's my mortality in the United States, or compare my mortality between countries in Central and South America. Maybe I'll be done in just a second. Dartmouth Atlas, anybody? Have people used Dartmouth Atlas before? This is a great tool. I really like it. I picked this one to show because it's so heavily GIS focused. You can pick different areas and zoom in. Let's go data by region. I'm going to choose hospital referral region, and then us. So what happens is after you enter this information, you can go ahead and zoom in on an area that you want. I haven't figured out how, it won't automatically zoom in for me yet, unfortunately. I can't figure out how to do that. Then you just view the profile, and then gives you the map of the area, shows you some key statistics, and then you can customize a report, for example, hospital capacity. Let's just say I wanted to compare it to other counties in this area. Makes it very easy for you to go ahead and pick a few others down. Say Orange, San Diego, San Diego. And as you can see, they have other ways of displaying this information. The particular data set that I pulled doesn't look good at any other, doesn't look go any other way, but you can do that as well. The last one comes out of the kind of like county health rankings. This is always depressing to look at. My favorite stat, morbidity, rank out of 5649. Great. But it's a really good tool that is fairly new. Again, complex answers, complex questions. You can use this to help generate a simple question, a simple answer too. Keep in mind that with tools like Wolfram Alpha, you can actually take the results from these complex systems, like the data output from county health rankings or the PAHO data, and use those to feed other decision support systems that can provide information that's more easily processed. So that is pretty much all we had for today. We just want to open it up for some questions.
I want to thank Jean and Paul for the presentation. I know they went through a lot of things very quickly. To start us off, Dr. Neil Kaufman, who has developed some very interesting patient management technology. Actually, you'll describe it better in a sentence than I will. Is going to start us off with a question for Paul and Jean about their presentation and about how we can better use health information technology to inform and advance both health policy and clinical planning and decision making.
Thank you. So my name is Neil Kaufman. I'm faculty, School of Public Health, and co-founder of the UCLA Center for Health, Children, Families, and Communities. And up until 6 years ago, I had a 27-year career in academic primary care pediatrics and public health. And 6 years ago, left my endowed chair at Cedars and set up a software development company. Someone told me the other day, I guess I reinvented myself. I didn't know that I did that, but I guess I did. And I really enjoyed what you presented, and really just want to make a very quick comment. Thanks, Rick, for giving me the opportunity. What you talked about primarily was how do you make the health system more efficient? How do you make it maybe more effective? And then how do you think about large data sets? There's a place in the middle, which you didn't talk about, and I know you can't talk about everything in 1 hour, but to me the critical area that perhaps some of the people in this room would be interested in is how do you, I'll use the word combat, direct to consumer, direct to patient, access to a range of things as sexy as an iPhone app with no evidence, nothing behind it whatsoever, to help them change their behavior. If you look at all of the evidence, about 10% of the variance on prevention of premature death is healthcare related, about 30% is your genes, about 20% is your environment, both the toxic environment and how good it is, but 40% relate to your behaviors. And if we don't, as a health system, understand how to provide improved behavioral support that's efficient and effective in the context of a clinical relationship, I think we're not going to get any of the goals that we want to have. So when you look at personal health records as they link into electronic health records and electronic medical records, to me the key question is how do we as a health system go beyond what we've been doing so far, which is helping to make us more efficient, I hope, perhaps more effective, but actually to serve the patient, particularly in a public health perspective, when you want to care for large numbers of people one at a time. So I don't know if there's a question in that, but a philosophical one, certainly there's a policy-related question, because
Services to the point of care. So people in the physician offices or physician extenders or clinicians can actually do a lot of outreach and reach out and touch them. I think they benefit from having a relatively small population as well. Know in that once they leave the physician office, then there's still that gap. Europeans in general have been much more proactive in using text messages as health prompts and health reminders, and I think that we've seen some studies recently in the US. I think there's one at UCLA right now looking at adolescent medication use that with text message reminders that it has shows promise as well, because what we're doing through capturing people in their workflow or in their daily living.
Any other questions? Yes.
Yeah. 35-year healthcare practitioner in management. What, from a policy standpoint, do you see happening, if anything, in terms of moving this whole initiative down to the basic educational level of the healthcare provider system, starting with medical school students, nursing students, pharmacy students, in terms of getting them to appreciate how their future is going to be different with this whole initiative?
Well, we're working very hard to try and establish educational programs. So I think you get lots of agreement as far as the importance of doing that. Again, this is where I think it is a societal evolution, because it's going to reach into all of our lives in all those ways, to somehow figure out what's the balance between where we are and vision of being able to operate from our iPhones or have perfectly reliable information that's organized in our institutions, and it's just a seamless flow. Okay, so right now, and I've looked to find other programs and things like that. I know that the new graduates, medical graduates, are getting more education now in this. They're being trained, using systems and electronics more. But I don't know how in-depth that is, other than to use the systems rather than to understand kind of how they're evolving. I know that people who are trained as healthcare managers and others are not, there's a handful of good programs in the country. So that's part of the evolution that's going to happen. We're not there yet. That's still in the 10 to 15% range.
Actually, I have two short questions. The one is,
Simple questions for simple answers?
A little louder, Hong Chen, please.
Okay. Do we have a national standard in developing those information system, like a medical record system? No?
No, we do not have national standards, which is one reason why some of the countries that Rick was mentioning do have a better shot at this, is they get their arms around it, they've got a more kind of social, broad approach to it, and they standardize things quicker. And in the United States, that is kind of a bad word, right? You can't tell anybody anything, right? And let the free market reign, right? Which is exactly where we are. But with a lot of government as part of that too, and a lot of people making a lot of money off of it. So you've got a lot of self-interest that's driving the engine here. And so we need standards for data. I honestly think that somewhere between, I still know that we've got to have data that's organized and accurate inside wherever care is taking place in order to be able to achieve the vision that Paul is seeking here. And I think that we have to make sure that standards are the key. I mean, they really are the key. Standards for data definitions, standards for, we could have different kinds of systems, but if we had standard data nomenclatures, it's really about the information. It could be on an Apple or a PC or whatever, right? It's the data that really matters, and then we can share the data around and have exchange and things like that. So I think technical standards for the exchange, data definition standards. We are right now, just as an example, moving from ICD-9 for the codes for diagnoses to ICD-10, which is going to be happening in the next several years. That's going to be crazy because there are so many more codes right, in ICD-10, like tens of thousands more codes. And all of our systems are set up for ICD-9. So it's going to be Y2K and then some, right? So these are all things that are going to affect us again. This is evolution. It's like we're crawling out of the ocean and we're trying to stand up, but we're not really standing up yet. Sorry.
The second part is, how do you tell, given so many websites, how do you tell which site is more accurate and more reliable in providing health information? To me, I'm a statistician. To me, if there's no confidence in the law, I'm not.
Jen wants the confidence intervals for those answers as well.
The websites I show were really to address a lower common denominator than yours. I think that the websites that I did choose are using validated data on the back end that do have confidence intervals associated with them. However, all you have to do is Google certain terms and you'll get different data sets that are perhaps not as rigorously validated before they put out. So it's one of those buyer beware type things.
I will say AskGIS does provide confidence.
You know, I think, I'm sorry, researchers still, I mean, this is the role then of the PhDs in the world, right? Is to make sure that all these sources then, that our jobs change, right? Now it's our job to somehow engage in that whole process and make sure the data that are used for research are you know, reliable, accurate, valid, all those good things, and accurate. So, I mean, it's a good question for you, right? No, go ahead.
Yeah, I think kind of from a holistic idea, while you're doing the technology, I'm very involved in the South Los Angeles community and starting to educate the community on the availability of telemedicine, so that while that becomes available, we still on parallel have to be, the other individual that talked about how do you educate and bring, I think, people like the self-knowledge of how to educate them to do it. But I will tell you, the gang members have iPods. I mean, so, and there's a lot of things that we can be doing that needs to be done, I believe, in parallel, where you educate that and you find the resources in those communities. Like, for example, churches are very active in those communities. And I've been very active with those, for example, to bring that knowledge in. So I suggest that while you do that, make sure that in parallel, so that when you roll that out, kind of on a return on investment, the end users are already there.
So there's a need to invest in education and dissemination to broader communities, including communities that have low levels of technological capacity to start with, to enable them to participate and be a part of it.
Well, they don't have computers. They've got iPods and other devices. So
Cell phones, right. And this is an area of all of the evolving technologies. I mean, part of the trick of all of this is to always, whether it was in the 70s with mainframes and moving to the mini computers of the 80s and things like that, it's always, you've got to be looking ahead. You've got to be looking 15 years ahead and saying, okay, what's coming, and try and, not to borrow a phrase, but, you know, skate to where the, where the puck is going, right?
Shayna.
So kind of linking the two sides of your talk together, because Paul, you presented websites that were very population data focused, and then Jean, you were talking about, you know, medical records that seem very patient-centered and organization-centered. Do you ever see a time, or is this even in the pipeline, where there might be some kind of linking between those two, where you would get a public kind of website at an aggregate level that you'd be able to look up population data that's from all of these kind of medical records thing, or people could go in and keep their own personal health record online as kind of their own repository if they don't have, you know, something to keep it on home, so that any of their providers could go and look at that. Is that something that's happening too, linking all those things together?
I'll say first, I've got the mic, and then Paul can go for it, but absolutely, yes, I think these things are going to start to converge. I happen to be a big believer in the personal health record, and smart cards are one form of that right now that exists. And again, other countries somehow, you know, sometimes get their arms around these things better than we can in the United States. But I do see that done correctly, the lines really start to blur between organization-centric information and public health, you know, like medical informatics and public health informatics, the lines start to blur, whereas now they're rather distinct in some ways, and part of that is just because of our constructs and our tools and our realities around organizations. So I think as a culture and as a world, as lines are starting to blur between who's got the information, right? Now that we can all do our banking online and whatever else, the lines of the institutions are starting to melt away. So I absolutely hope that we don't have to have separate systems for public health informatics and organizational things, that these things are able to flow. And again, the key is going to be standards technically and data standards and things like that.
I think in like an information utopia, there's no line. It's all
Right.
seamless from the day you collect it at your point of care to the day that somebody uses it for a population level analysis. It's all continuous. But the reality of our existing system is that you have competing healthcare provider organizations, you have competing federal and state organizations, and I think you fractionated the data silos. And so you're basically kind of going around the back end to try to pull it all together again to make it work. Some of the research that's been done on PHRs, personal health records, show that it's a great idea, but nobody wants to enter the data into the system, and that represents one of the greatest challenges.
Can you say one more thing on that?
The ideal world we talked about would be fabulous, and I can imagine you extending further to non-medical providers who have access to these systems so that everyone who's interacting with an individual has a capacity to communicate with one another. But the one thing you haven't talked about, although there was a hint at one point, is this raises huge privacy and security issues.
Absolutely.
Particularly in the United States,
Right.
and for all the reasons that you mentioned. So where are we with that, and how can the security side and trust in these systems without privacy advance along with the technology itself and the information that's available?
I've got something to say.
Okay.
You go first this time.
It's so bad that there's actually a website that logs every single privacy and security breach, and they update it at least a couple times a day. I mean, that's the biggest issue, is that as somebody who has done a fair amount in the information security area, I have zero confidence in the ability of any healthcare organization in the United States to maintain a completely secure medical record.
With that said, on that cheerful note,
Yes, it is.
Well, I think I have your medical record on my iPhone.
well, it's interesting. Some people would be just as happy to email their physician about results and whatever else, and just send it on email, and they don't care. Whereas it is very important to achieve security and privacy. We can't just regulate that away, but we have to try to do the absolute best we can. I think we always, in developing new systems and new ways of doing things, we imagine nirvana, or even just great things that could come out of having an electronic health record, or having connected to your clinician, from home or whatever. And so we say everything else is therefore lesser than or not good or something. And I don't really believe that. I think we have to be trying to make progress in all things as we move forward. We have to be smart about how we do that and not waste time. I don't think we're wasting time now because we're evolving. But it's painful. And we have to be careful not to invest too much in solutions that are going to be legacy before they're built. But pretty much it's always been that way in technology. So it's just, we have to keep trying. And I have to say one thing on the last question too. I think that it is a laudable goal for us to really try to improve the work experience and workflow of clinicians and their interaction with patients and with each other. I think what we've done with, kind of forcing people to work according to how a system is set up or according to how our payer gets paid, and we've done it ourselves because of our fee-for-service reimbursement system over the years, and then all this health plan jazz and all of that, kind of the tail wagging the dog, is we force clinicians to be something other than clinicians for far too much of their day. And we have to get better in terms of how we integrate systems into workflow and vice versa. We have to be able to have the courage to streamline and, we're talking about human beings changing how they're working. And that's very threatening to most human beings. You know, we've all got initials and hats and, you know, societies we belong to, and so we're asking people to give up some tribe that they're part of and share, you know, hold hands and sing Kumbaya and work together, right, to get benefit for the whole and for the patient. So improving the experience for clinicians, because there's a lot of people who don't want to become clinicians anymore. How many people want to be a nurse, right? Well, maybe it'll get better. So we have to start to improve the work experience of our people who take care of patients and others. These are important people in our culture. So anyway, off my soapbox. Yes.
Question.
My question has to do with the ethical standards that is supposed to be developed at a policy level for those who actually are getting funds to take our medical records and be managers of it. And there has not been any policy or standard placed regarding that. All these people are getting funds because they know a little bit about some technology or something, but their ethical processes on how they're going to deal with our data, not only that the technology would keep our privacy and security or the ability of the technology, but actually the individuals who are given the opportunity to take our data and manage it have to have a certain level of ethical standard. And that is actually missing, and that's a key important category that needs to be developed in a policy.
Right.
Just a quick comment. The HIPAA privacy regulations actually do address the ethical component for the requirement to safeguard patient protected health information. It's one of those things that you have to sign that nobody reads, but basically says that you take it upon yourself, you have an ethical requirement to safeguard this information. So they do address it. Now, how do you enforce compliance? Well, that's always an issue, but that applies to not just healthcare data, but any data.
Alberta, last question, I think, because time is running out.
Yeah, I'm interested, and I think this brings together all the last questions in knowing how you address the end consumer education, you know, the patient education. We're used to working with data, and we know how you can strip only the portions of data that you actually want to work with that are non-identifying. But from a patient perspective, it's my medical record, it has all of my information, and I'm hearing more and more from, you know, friends who have children who are thinking to switch in light of the electronic medical record to providers that don't use computers, that only have paper records. The concern being that there is this sort of big brother that watches over medical records, and in the future, if my child is overweight or has asthma, he's not going to be able to, say, get health insurance. So how, you know, as part of this change, which is huge, how is the consumer educated? How do they become part of the process and embrace the process rather than being just subject to it?
Well, I think even though I said I think the EHR stimulus money is a waste of money.
Heresy.
Heresy, I know. Sorry, you want to wreck, right? Sorry about that. I think that the benefits of an EHR cannot be underestimated, cannot be overestimated. You're able to aggregate data for an individual patient so much better than you would be able to do with paper records. So I think the benefits are absolutely there. But what I think is missing is, like you said, the link to the patient. I think that's the key component that we don't have very well funded right now. I think largely because it is very much a moving target. You have different educational levels, you have different social and cultural expectations. So I think it's a difficult proposition to do in a standardized format, which is one of the reasons why I still think it's in the research area. But from a security perspective, I'll just leave you with a quick note. Motorola, back in their late 90s, had an employee saw a doctor prescribed a medication for insomnia, which was an antidepressant. The PBM, who handled the claim, enrolled her in an antidepressant behavior modification program. And of course, that now dropped into her medical record. So the next time she showed up to her doctor, he asked, how long have you been depressed? Mm-hmm. So, and that was all by a completely legal exchange of data that was permissible under the HIPAA regulations. So it's not just not trusting people being able to secure the data, it's how the data is transmitted and how the data is used.
Right. I mean, just to add the thought, That's an ethical question. It's a question about our society and how we choose to be with each other, right? And how health plans might behave about that. So it's a bigger question than I think what these tools have the power to control. What we can do is do things with privacy and security, but if that's how a health plan behaves, I mean, I think as a society that becomes a broader question is, are we going to allow for that kind of thing? Or are we going to take care of people as they are? And so I think we can only answer some questions with what we have here.
Before we close, I want to let you know that Gwen is holding up a sign-up sheet. If you would like to get noticed about the seminars that we have every month, please make sure you are signed up on it if you haven't already received an email about this one. And I want to thank Hala Douglas for organizing this seminar, as she does others. And, most of all, I want to thank our speakers, Jean Balgrosky and Dr. Paul Fu, for their presentation today. Thank you.
Are we done?